Good evening, everyone. So we are back once again with the renewal round webinars, and with us is none other than Dr. Ajay Kher, who is extremely well known to this audience now. And today he will discuss one of the most common and one of the most important clinical problems that we often encounter in clinical practice day to day, both in outpatients as well as inside the hospital, that of metabolic acidosis. So he will tell us exactly how to go about deciphering the various causes of metabolic acidosis and how to go ahead and manage patients with metabolic acidosis. So over to you, Ajay.
Thank you, Dr. Jha. So the outline for the talk is that we've already discussed a couple of these issues, so I'm actually not going to touch on them in great depth this time around. So how to evaluate an ABG. So we've done a full session on it. And the acid-base homeostasis and acid-base physiology, we've done a full talk on as well. So this time I'm mostly going to focus on etiology, differential diagnosis, and treatment or approach to treatment. We'll touch a little bit about some of these other issues while we discuss them, but I won't be focusing on them. So we'll start with a case. So we have a 55-year-old male with alcoholic cirrhosis and presents to the emergency department with some diarrhea. And the labs show that the sodium is 138, potassium is 3.0, chloride is 110, and the bicarb is 18. So what is the next step in managing this low bicarb? So should we give this patient some IV bicarbonate? Should we give him some sodium bicarbonate orally? Should we check an arterial and venous blood gas? Or should we give him potassium for his hypokalemia? So one of the key things that I would want everyone to take home is that before we label someone with a low bicarbonate as having acidosis, we should confirm and check a pH. So the answer for this is that we should at least check a venous gas or an arterial gas, whichever one is convenient, to make sure that this person actually has acidemia and acidosis and doesn't have respiratory alkalosis, and the low bicarbonate is the appropriate compensation from the kidney. And this is especially in those who have high possibilities. So like liver disease, which this patient has, a lot of patients will have respiratory alkalosis and the bicarb is appropriately low. So pregnancy, fever, neurological disorders, or pulmonary disorders. So someone has a history of this or is known to have an acute illness. In that situation, before we label them as having acidosis or acidemia, we should at least make sure that we've checked their pH at least once. So that's kind of the first thing to say. So let's look at another case. So this is a 30-year-old tea plant worker who's brought to the emergency with complaints of blurry vision, vomiting, and disorientation. His blood pressure is 100/50, heart rate's 110, and his labs show that he has severe acidosis and acidemia with a pH of 6.9, PCO2 of 20, PO2 of 90, and a bicarb of 4. Sodium is 140, chloride 96, and bicarb is 4. So how do you evaluate his acid-base disorder? So most of this has been done in the previous talk when we talk about how to evaluate ABGs. So we'll just go over that again. So the steps for evaluating an ABG that work for me are: the first step is to look at the pH and to see if this person is acidemic or alkalemic. In this case, there is severe acidemia. Second is to see if it is metabolic or respiratory. In this case, with a bicarb of 4, this is metabolic. Step 3 is to see what the respiratory compensation is, or whatever the compensation is. In this case, the primary event is a metabolic acidosis. So for every 1 drop in bicarb, the PCO2 should drop by 5/4. So the bicarb has dropped from 24 to 4. So that's a drop of 20. So we multiply 20 by 5/4, and that gives us 25. So the PCO2 should have dropped by 25. From 40, it should have dropped by 25 to 15. But currently, instead of it being 15, it is 20. So there is a small amount of respiratory acidosis because the PCO2 has not been blown off as much as it should have. So there is a small respiratory acidosis in addition to the severe metabolic acidosis as well. Step 4 is to look at the delta-delta and the anion gap. So the anion gap in this case, which is sodium 140 minus the chloride and the bicarb together, which is 100. So 40 is the anion gap. So the delta-delta, which is the change in the anion gap, normal anion gap being 10. So the change in anion gap is 30. And the change in bicarbonate is gone from 24 to 4, so that's a change of 20. So 30 by 20, so that's a delta-delta of 1.5. And the normal delta-delta can be anywhere between 1 to 2. So in this case, there is no additional third acid-base disorder. And at present, there is only anion gap acidosis and a respiratory acidosis. So that's kind of the steps that we've talked about before as well. And those are the steps in which I would assess the acid-base disorder. And so the next and the last thing is why, and then you go about fixing it. So in this case, I've given some clues already as to the anion gap acidosis. And we look at the differential for the anion gap acidosis. So the usual mnemonic that people use is mud piles, and it stands for methanol for M, uremia for U, diabetic ketoacidosis, and then I tag in the alcoholic and starvation ketoacidosis there with it. Paracetamol with the 5-oxoproline, which is the new or relatively new thing in anion gap acidosis, with the old ones being paraldehyde, and then propylene glycol, which is used as a solvent in for lorazepam, and over long infusions can accumulate and cause an anion gap acidosis as well. With I, you have iron, isoniazid, and inborn errors of metabolism. L is lactic acidosis, both D and L lactic acidosis. E is ethylene glycol. S is salicylates, which is usually also associated with some respiratory alkalosis. And then there's a new addition to it, which is mud piles with CAT. The CAT stands for cyanide carbon monoxide. A is for the alcoholic ketoacidosis, and T for toluene. So if you want to do the new one, it's mud piles CAT, or that. Another way of looking at it is just focus on the big ones, which is the lactic acidosis and the D-lactic acid, keto acids, ingestions, the new acetaminophen, pyroglutamic acid or 5-oxoproline, and then renal failure in which sulfates and phosphate accumulate. The other acidosis is the non-gap acidosis. So the differential for a non-gap acidosis is predominantly diarrhea or high ostomy outputs, carbonic anhydrase inhibitors, a urethral diversion like an ileal loop, post-treatment of a diabetic ketoacidosis, and we'll talk a little bit about that. Any kind of renal failure, AKI or CKD, and then the different renal tubular acidoses, which is the type 1, which is distal RTA, type 2, proximal RTA, and then the type 4, which is the hypoaldosteronism. So let's look at another case. A 40-year-old male with a previous history of small bowel resection after gunshot wound notes that he feels drunk even without any alcohol intake, and has episodes where he has confusion, cerebellar ataxia, and slurred speech. So what is the likely diagnosis and treatment? So is this alcoholic ketoacidosis, and for which he needs some IV fluids with dextrose and a multivitamin, diabetic ketoacidosis, for which he needs IV fluids and insulin, D-lactic acidosis with sodium bicarbonate and metronidazole, or ethylene glycol, for which bicarbonate and hemodialysis would be indicated. So let's look at the answer is D-lactic acidosis, and one of the key things is that the lactate that is measured for the usual methodology doesn't check for D-lactic acidosis. So when you do an ABG or a VBG, that will not pick up the D-lactic acidosis. So you need to have a chromatographic assay, in which case then you will also be able to pick up the D-lactic acid. It is also important to know that even in patients who have D-lactic acidosis, because the renal clearance is very high and it can filter out, you can have patients in whom the D-lactic acid had accumulated, they've excreted it in the urine, so that when you check, because of the loss of the D-lactic acid, they now behave or appear to have a non-gap acidosis, because all the D-lactic acid has been excreted and they have lost that potential bicarbonate, and so they now appear as a non-gap acid. These are usually in patients with jejunoileal bypass or a small bowel resection, or they have some bowel blind loop in which there is overgrowth of the gram-positive anaerobes with delivery of a high glucose or starch to the colon, which causes the production of this lactic acid. The treatment usually is a course of antimicrobials to cover anaerobes, usually metronidazole, bicarbonate, because the lactic acid, D-lactic acid will filter through the kidney, and so there'll be a loss of the bicarbonate or the potential bicarbonate. So you'll need to replace that. And then for the long term, these patients should be advised a low carbohydrate diet so that they don't have production of this D-lactic acid over time. So we'll use that as segue to talk about lactic acidosis per se. So the normal production of lactic acid is about 15 to 20 millimoles per kg per day. The glycolytic pathway or the deamination of alanine is the main source, and the liver and less the kidney metabolize lactate to pyruvate, and to CO2 and water, or they can metabolize the lactate to glucose as well. So let's look at the reactions a little bit. So the lactate with some oxygen can be converted to bicarb with CO2 and water, or the lactate can combine with water and CO2 to make bicarb and glucose. So either ways, this lactate, 1 mole of lactate will convert to 1 mole of bicarb, or 2 moles of lactate will convert to 2 moles of bicarb if it's making glucose. So either way, one lactate will generate a bicarb when it's been metabolized through the liver or through the kidney. So this lactate is a potential bicarbonate when it has been metabolized. The liver has a very high lactate clearance capacity, so as high as 1,000 ml per minute if it is working at capacity, and has good perfusion going to it. So most of the lactic acidosis are due to either a type A lactic acidosis, which is due to the tissue hypoperfusion, so any kind of shock, which is the most common lactic acidosis that we see. But there is type B lactic acidosis as well, in which the systemic hypoperfusion is not evident. So this can be someone with diabetes who's on metformin and then has some acute renal failure or chronic kidney disease, and his dose of metformin is too high. These are rare events. The incidence is low, and usually patients have some kind of acute renal failure in which the metformin accumulates and then causes the lactic acidosis. Others are malignancies, which can be a large tumor burden in which the tumor is making the lactate, or it can be replacement of the liver with severe liver mets or significant liver mets. And there are some patients who do not have either of those conditions but still have type B lactic acidosis, in which the exact etiology is not clear. Alcoholics can also have some type B lactic acidosis, though usually not in a very significant level of lactate compared to those with malignancy or with shock. Patients who have HIV medicines can cause mitochondrial dysfunction, can have lactic acidosis from those medicines. And then there is the malas with mitochondrial dysfunction and lactic acidosis as well. So again, going back to the concept of potential bicarbonate. So this applies to lactate, L-lactate and ketoacids. in which the lactate or the keto acid can then be metabolized by the liver and generate the bicarbonate. So once you correct the underlying process, it would lead to full normalization of the pH. If we give bicarb or additional exogenous bicarbonate in these kind of acidosis, then when the correction happens, it will lead to alkalemia. So if you have someone with lactic acidosis and you correct the hypoperfusion, for example, the lactate will convert back to bicarb. And then if you've given exogenous bicarb as well, the patients will get alkalemic. Uh, this is especially true for lactate because in most hypoperfusion states, the kidney and the kidney function takes a hit, and so the lactate doesn't filter or get excreted through the kidney. In comparison, when you have ketoacidosis, especially let's say diabetic ketoacidosis, many times the renal function is normal, in which case the keto acids can get excreted through the kidney and there is loss of that potential bicarbonate. And so in most patients with the diabetic ketoacidosis, once their anion gap acidosis corrects, you will find that all of them will have a non-gap acidosis that will be evident during that phase. And then with normal renal function, they'll be able to correct that and won't need any additional bicarb for that. Okay, so now I'm going to focus a little bit about one of the most common questions that come to us is how do you treat lactic acidosis and where and when should you use bicarbonate? So there are not too many studies on this, but there is one good study which has recently come out, so I'll focus on that. So this is the BICAR-ICU trial published in the Lancet of 2018. And they looked at 26 French ICUs, took patients from May 2015 to May 2017 that were admitted to the ICU with a pH of less than 7.2, with a PCO2 of less than 45 and a bicarb of 20. And they had to have either a SOFA score of more than 4 or a lactate of more than 2. They were randomized to either no bicarbonate, which was the control group, or 4.2% bicarbonate, with the goal of keeping their pH above 7.3 in those who were getting bicarb. The bicarb was given either 125 to 250 ml bolus in 30 minutes, and this could be repeated over time to keep the pH above 7.3 with the maximum of 1000 ml over 24 hours. The primary outcome that they had, that they were looking at, was death from any cause at day 28. And it was a composite endpoint with one organ failure at day 7. So I know the left side flow diagram doesn't appear probably too clearly, but they assessed 942 patients, out of which only 400 were randomized. So 540 potential patients were excluded. And so that is one of the critiques for this patient, for this paper, that the applicability of this to the general population of ICU patients who have lactic acidosis may be questioned. In addition, the 194 patients who were randomized to the no bicarbonate or the control group, out of those, 47 received sodium bicarbonate, with 41 receiving salvage therapy and 6 because of misinterpretation of the protocol. So about 24% of patients who were randomized to the control arm actually received bicarbonate, making the difference between the two groups a little narrower. So let's look at some of the baseline characteristics. So 80% of the patients were on mechanical ventilation and 80% were on vasopressor supports. The average pH was 7.15 with the PCO2 of about 37, 38 and the serum bicarbonate of about 13. Their serum lactates were between 5 and 6, and 80% of patients had a serum lactate more than 2 millimole per liter at the time that they were enrolled. And the serum creatinine average was 1.76 to 1.7. So in terms of the outcomes, so survival, if you look at that, numerically, the bicarbonate was a little superior, but it wasn't significant with a p-value of 0.09. They had an a priori plan of analyzing those with acute kidney injury separately. So when they looked at their patients with acute kidney injury, the difference in survival was significant, with the bicarb group in the blue doing better than the control group in the red, with a p-value of 0.028. And then they also looked at the differences across different subgroups. So you can see that those without AKI, the line crosses 0, and those who had AKIN scores of 2 or 3, which is what was significant in terms of the outcome that we talked about and the curves we showed before. All the other groups, age less than 65 or more than 65, sepsis or no sepsis, they cross the midline. And then the overall, all patients together also, the confidence interval crosses 0 with about a 10% benefit. So they also looked at renal replacement therapy, and again, the group that got bicarbonate had about 20 to 25% lower risk or lower need for bicarbonate, and that was significant as well. So that's the study that we have to look at bicarbonate for lactic acidosis. So what's the overall plan, or how do you approach someone with lactic acidosis? So the first thing that has to be remembered is that bicarbonate is not the solution. And the first and foremost emphasis has to be on reversing the underlying disease. So whatever is causing the hypoperfusion and the shock, we need to focus on fixing that as best we can. Keeping the pH above 7.1 till underlying disease reverses is a reasonable goal, but there isn't good human data for keeping it above 7.1 other than this one study. And this one was looking at patients with pH less than 7.2 and didn't focus at less than 7.1. There are harms with bicarbonate therapy that we need to know about. The first is that when we give bicarbonate, it will buffer the H plus ions and generate more CO2. So the patient has to be or should be adequately ventilated to make sure that the additional PCO2 that is generated is going to get blown off. Otherwise, that additional PCO2 that is generated will decrease the pH, and it will not correct the pH of the person. In addition, it is important to remember that the arterial PCO2 versus the local tissue level PCO2 may be different, especially in states where there is less or hypoperfusion and poor perfusion in those situations as well. There can be increased lactate production because the low pH turns down glycolysis. But now that we've corrected the pH, that feedback loop is going to shut down, and so there can be an increase in lactate production. Any rise in pH decreases the ionization of calcium and decreases the ionized calcium by buffering more of the calcium with the albumin. And so someone who has some low calcium can become overtly hypocalcemic. The bicarb that we give is a hypertonic solution with osmolarities that are in the 1,000 range. And so if we give enough volume of this sodium bicarbonate, then you can raise the sodium and cause hypernatremia. And so it might be better to give it with D5 on a long infusion rather than boluses if the patient can tolerate or has time for correction of the acidosis. In addition, whenever we give sodium bicarbonate, we are going to increase the extracellular fluid volume, which may be a good thing for some patients, but it may be if it's a cardiogenic shock or someone with pulmonary edema, then that may worsen the situation as well. So again, if anyone has mixed respiratory acidosis and a metabolic acidosis, the first thing should be to make sure you increase their minute ventilation and adjust their either respiratory rate or tidal volume, because whenever we give the bicarbonate for the lactic acidosis, the increased PCO2 is going to be an issue. The reason to consider giving bicarbonate is to prevent the following. One is there is animal and tissue level data that a low pH less than 7.1 is associated with a reduced left ventricular contractility, with arrhythmias, can cause arterial vasodilation and venoconstriction, and impairs the responsiveness to catecholamines or vasopressors. So giving bicarbonate and increasing the pH would help prevent these issues. So it is also important to kind of, again, keep in mind that the tissue hypoxia may dramatically increase the lactate production, and the reduced clearance of the lactate by liver, heart, and the kidneys is the key reason why someone is continuing to have lactic acidosis. And this combination of tissue hypoxia and the reduced clearance can easily overwhelm whatever we are doing exogenously. So the key has to be to try and correct the tissue hypoxia, the tissue hypoperfusion, and the perfusion to the liver and the kidney, so that the lactic acidosis generation as well as clearance of the body improves. Because no matter what we do exogenously, the body itself can completely overwhelm all our efforts. So take home from this part is that if the pH is less than 7.1, we can give, and the bicarb is low, then we can give bicarbonate, but we have to ensure that the patient is ventilated, or that they are already have a PCO2 of less than 15. We should check an ionized calcium, and if it is low, make sure that we replace it before we start the bicarbonate. Otherwise, we can precipitate someone with severe hypocalcemia. And the usual dose to give is 1 to 2 milliculons per kg. And you can repeat it in 30 to 60 minutes after you've measured the electrolytes and the pH to see the impact that you've had. So just a quick note on cardiac arrest and bicarbonate. So there have been a few studies, I've just mentioned a couple of them, that have shown that pre-hospital cardiac arrest or out-of-hospital cardiac arrest were where they were given bicarbonate did not change the outcome, and so ACLS also recommends against use of bicarbonate in cardiac arrest. So now we'll switch gears and talk a little bit about ketoacidosis. So the treatment for this is focused on treating the underlying condition. So if it's diabetic ketoacidosis, IV fluids with normal saline and insulin is going to be the treatment. For alcoholic ketoacidosis, dextrose, saline, and multivitamins, and then nutrition. If you have all of them, as we talked before, with diabetic ketoacidosis, will have ketoacids that will be excreted in the urine. And so because of that, there will be potential bicarbonate which has been lost. And so that bicarbonate loss will lead to a non-gap acidosis that will be there during the treatment. However, patients usually would not need additional exogenous bicarbonate because the kidney will be able to handle it and excrete the additional acid and correct the acidosis. It is also important to note that if you have an end-stage kidney disease patient who develops diabetic ketoacidosis, one, they will not have the volume loss because they don't have the hyperglycemia and the glucoseuria, or the ketoacid loss because they don't have that. So you usually just need to give them insulin without too much fluids to correct their diabetic ketoacidosis. So now we'll switch to the patient that we talked about, the tea plant worker. So this has been in the news a lot lately with Assam. And so we'll talk a little bit about now how do you manage his acid-base disorder. So this with the blurry vision is indication that this is likely to be methanol, and you can confirm it by doing the osmolar gap as well as doing specific methanol testing. So the treatment for the toxic alcohols, methanol and ethylene glycol, is to first correct the acidosis the best you can with bicarbonate, addition of ethanol or fomepizole, whichever is available, to inhibit the alcohol dehydrogenase which will help prevent the further metabolism of methanol and ethylene glycol, so that because those are the products which are toxic, and then hemodialysis to clear both the methanol ethylene glycol as well as its metabolites. And usually there is a need for long sessions of hemodialysis. There are a couple of papers that I've quoted below from Kidney International in 2001 and 2017, which have formulas which you can use to actually predict the duration of hemodialysis. And this can be based on either methanol level, ethylene glycol levels, or actually, if you can even just get an osmolar gap, you can use that based on their molecular weight to predict how much ethylene glycols and millimoles per liter is present, and then use that to calculate the duration of dialysis. Another cause of a high anion gap acidosis is 5-oxoproline, which acetaminophen, paracetamol can generate. And it's usually seen in patients who have glutathione deficiencies, so women with chronic illness, malnutrition, or those who have diabetes, chronic kidney disease, and liver disease. The glutathione deficiency causes the accumulation of the 5-oxoproline. It can also be a part of inherited disorders in which the glutathione there is a block in one of the hormones leading to its metabolism, and so that can cause 5-oxoproline to accumulate. The treatment is to give bicarbonate to correct the acidosis, and then if it is due to acetaminophen, holding the acetaminophen and let the body metabolize it there. For those who have acute acetaminophen poisoning and liver damage, there is evidence to use N-acetylcysteine to correct the glutathione deficiency and help the disease process. But for this acidosis, at present, there isn't evidence to state that giving N-acetylcysteine is going to help it. But because physiologically and mechanistically it seems to make sense, some people do use N-acetylcysteine to help correct the glutathione deficiency as well, though the evidence at present is lacking. So patients who have acute renal failure or chronic kidney disease, so with there can be an anion gap acidosis or a non-gap acidosis. It depends on which part or function of the kidney is hampered. So if the GFR is the main one with the tubular function being maintained, then you're going to have an anion gap acidosis with the accumulation of the sulfate and the phosphates, which are going to be unmeasured anions. And if the tubular function is the one which has been hit first, then there's going to be decreased hydrogen ion secretion or ammonia generation is going to be impacted, and so that is going to lead to non-gap acidosis. The correction of the acidosis is associated with good bone health and may also be associated with slowing the progression of kidney disease. However, whenever you give someone sodium bicarbonate, you have to also be careful about their volume overload or the volume status to make sure that you are managing that and not worsening their volume and hypertension and edema. So let's look at another case. This is a 50-year-old male with currently suppressed hepatitis B on tenofovir for 1 year and presents with severe weakness. The labs show a sodium of 136, chloride of 110, bicarb is 16, creatinine is 0.8, calcium is 9, and phosphorus is 1.5. Glucose is 80, And then the urine has a specific gravity of 1.010, pH is 7, and 1 plus glucose, even though the serum glucose was 80, and trace protein and amorphous material seen in the urine microscopy. The ABG shows a pH of 7.32 with a PCO2 of 32, oxygen of 90, and a bicarb of 16. So this isn't going to be a surprise to anyone that this is a tenofovir-induced type 2 RTA. And so type 2 RTAs have proximal RTA, and there's diminished bicarb reabsorption. The urine pH can be variable, depends on whether someone's already on bicarb replacement or not. If they are on bicarb replacement and the bicarb level is above the threshold for that RTA, then the urine pH is going to be above 5.3. If they're at the threshold or below, then the urine pH is going to be 5.3 or lower. The plasma bicarbonate usually is between 14 to 20, and that's because the distal function of the kidney is still present. The fractional excretion, if we supplement bicarb and get their bicarb to 24, the fractional excretion is going to be very high because it's a proximal deficit, and is going to be in the 15 to 20% range. Patients can, especially if they're kids, can develop rickets and osteomalacia. And depending on the severity and the level of proximal RTA, they can be associated with loss of phosphate, glucose, and amino acids as well. The causes for type 2 RTA can be primary, idiopathic, or hereditary, with a long list of hereditary causes. In terms of acquired causes, myeloma, drugs, and Sjogren's are other etiologies. So treatment is to give sodium bicarbonate or potassium citrate. Citrate is usually better as it is better tolerated. And you also need to give them potassium because of the heavy bicarb loss. There's going to be potassium loss as well. And there's usually a large amount of bicarbonate or its equivalent that you are going to need to give, because they're going to continue to filter and excrete 15 to 20% of the bicarbonate that you give. So they may need up to 10 to 15 millicoulomb per kg per day for correction of their acidosis. So now switching gears to type 1 RTA or distal RTA. So this is, the mechanism is decreased distal acidification. The urine pH is going to be more than 5.3. The plasma bicarb can be very low, including less than 10. And this can be associated with nephrocalcinosis and renal stones. The causes are primary or hereditary, or can be autoimmune, and can be drugs as well, including ifosfamide and Sjogren's. The treatment for type 1 RTA, the focus is to have a normal growth in the children, minimize the stone formation, and decrease the risk for osteopenia. For adults, the requirement is usually low in the 1 to 2 millicoulombs per kg per day, but for kids, it might be higher in the 4 to 14 millicoulombs. And you can use sodium citrate or sodium bicarbonate, because once the acidosis is corrected, usually they don't have a significant potassium loss. So now I'll kind of just summarize the principles of therapy. So the first focus has to be on reversing the cause of acidosis. In patients with acute metabolic acidosis, bicarb may be given for those with a pH of less than 7.1. This is based on animal and tissue data, and there isn't good human data for that. Patients who have a pH of 7.1 to 7.2 with acute kidney injury, based on the BICAR-ICU study, there is good evidence to state that we should consider giving them bicarb for survival, as well as decreasing the need for a renal replacement therapy. For those with chronic metabolic acidosis from diarrhea, CKD, or RTA, the increasing bicarb is good to decrease the respiratory drive, to decrease the impact on muscles, skeletal growth, as well as skeletal integrity. And in type 1 RTA, also for prevention of nephrocalcinosis. And in CKD, there may also be decrease in the progression of CKD, based on a few studies that have suggested that. The amount of bicarb to give is mostly empiric, and there can be if you're giving more than one vial, then it might be better to give it in an infusion, or to give additional free water like D5, or through the RT, through the Ryle's tube, or to make sure that the patient doesn't get hypernatremic. If someone has chronic needs, then potassium or sodium bicarbonate or potassium citrate or lactate may be a better choice, and that can be given. And sodium bicarbonate 500 milligram has only 6 milliclins if someone is trying to calculate that as well. The bicarbonate calculation can be done, but unfortunately bicarbonate is not a fixed space, and so calculations are very empiric, and because the bicarbonate is going to get buffered. So if you look at how much space or volume the bicarbonate is distributed in, or when you try and calculate, so for someone who has normal or a mild deficit, it is going to be 55% of body weight, the volume of distribution for bicarb. But when they have severe deficits, it's going to be even up to 70% of body weight. And when it is less than 5, then it is even more, greater than 100%, because as soon as you give the bicarb, it's going to buffer, and then the CO2 is going to be generated, and that's going to be blown off. So the volume of distribution is almost impossible to calculate in that kind of situation. One way of doing an estimate, so you have at least a sense of how much bicarb you will need to raise, is to, let's say you have a bicarb which is low at 6, and you want to raise it by 6 to get them to 12. So you can take 70% of body weight. So if you have a 60 kg person, 0.7 into 60 multiplied by 6, you get 250 milliclins. So you will need 5 vials of 50 MEQs over 4 to 8 hours to get the bicarb from 6 to 12. However, these are all very crude estimates and calculations, and ultimately the lactate production and the lactate clearance from the liver are going to be the actual drivers of how much buffering actually happens and how much the bicarb will respond. To summarize, so the first thing is, before you assume someone who has a low bicarb has acidemia, check a pH. The common causes of anion gap acidosis is mud piles cat. Treatment of the underlying disorder is the first priority, and there is a limited role for IV bicarbonate in those patients who have potential bicarbonate like lactic acidosis and ketoacid anion gap acidosis. And for all other patients, IV bicarbonate to correct the acidosis is required. Thank you, and I'll now take some questions. Hello.
Hi, thanks Ajay for this wonderful talk once again. I think we already have some questions, and Dr. Sashi Kiran has a question. So I'm going to unmute you, Dr. Sashi Kiran. Please go ahead and ask your question.
Anything? What's the thing? What do you want? He already unvoiced. We can ask. I do that. What the question? No problem.
Hello, sir. This is Shashi Kiran. I'm calling from NIMS, Hyderabad.
Sir, you're able to hear us?
Yeah, I can hear you.
Our voice is audible, sir?
Yes. Go ahead.
Yeah, please. Dr. Shashi Kiran is going to ask a question.
Sir, how to go about the correction of severe metabolic acidosis in a CKD patient who is on CKD5, who is already on hemodialysis? Yes, sir.
Okay. So if they have so the cause of the severe metabolic acidosis is lactic acidosis, or you're talking just general CKD patient who is on his maintenance hemodialysis and just coming in with a bicarb of, let's say, 15 or 16?
He is septic and he has come with severe metabolic acidosis, sir.
So if they've come with severe septic metabolic acidosis, meaning lactic acidosis due to shock, then the first thing is going to be, again, to focus on trying to correct the sepsis and the shock. And as part of the lactic acidosis, as I said, there is some evidence for giving bicarbonate with pH in the patients with acute kidney injury. But in this patient, this is an ESRD patient, so you're going to need to probably do some kind of SLED or CRRT therapy as well to remove some of the lactate. But ultimately, the lactate should get cleared by the liver. So as long as you correct the hypoperfusion, the shock, and the liver gets perfused, the lactic acidosis is going to get converted back to bicarb, and that is going to be the best way of treating someone with this kind of a situation. However, in the meanwhile, you could consider doing a SLED or CRRT in the setting of the shock to correct the acidosis till the other therapies kick in.
Sir, do I have to make any changes in the dialysis fluid which I use for such a patient regarding the
Sure. So usually most of us would increase the bicarbonate to the maximum bicarbonate to try and help deliver as much bicarb we can to the patient. Again, I can't say that there is good data for it or evidence for it, but that is something which everyone does. The lactate will get cleared through the machine as well at a clearance of around the urea clearance. But ultimately, it is not the machine which is going to fix it. The machine is only buying time till the sepsis, the shock, the cardiogenic shock, whatever it is, gets better. So unless that gets better, this is just a band-aid. Unless the internal mechanism of the shock gets better, this is not going to go anywhere.
Thank you, sir.
Thanks. I think there is a question from Dr. Shiv Shankar Verma. How to manage type 4 RTA in diabetic CKD?
So I actually didn't touch type 4 RTA, mostly because that's something that in terms of the acidosis is not as much of an issue. It's more a hyperkalemia. And usually these patients can be managed most of the time with some diuretic for both their hypertension as well as their hyperkalemia. Occasionally, some of them may have very recalcitrant hyperkalemias, in which case some people tend to use some fludrocortisone to correct their hypoaldosteronism, but I would try and focus more on using diuretics and optimizing the diuretics as best I can to correct their hyperkalemia, because aldosterone, especially in diabetics and those with heart disease, is going to increase their cardiac risk. So I would try and stay away from it as if possible.
Thank you, Ajay. Dr. Shiv Shankar Sharma says thank you. Dr. Samir Bhuwania also really is appreciative of your lecture. I think that this lecture was really very, very clear, and the kind of examples that you gave and the solutions that you suggested, they were fantastic. And I'm sure they will be very, very helpful to almost all the participants who are on the call right now, and a large number of people who will subsequently watch this on the YouTube channel to understand metabolic acidosis and manage patients with metabolic acidosis better. Does anyone have any other questions? Well, if not, then once again, thanks Ajay as always, and we will look forward to your next talk.
Thank you so much.
Bye.